You know, if you've ever owned or really truly cared for an athletic horse, you probably know that feeling, that little pit in your stomach when something just seems off.
Hmm.
Maybe a tiny change in how they move or, a subtle stiffness that just wasn't there
Yeah,
yesterday.
that initial worry.
Exactly. It's that immediate concern about something that's actually a really common challenge in equine health, something that can really affect their performance, their comfort.
Absolutely.
So today we're doing a deep dive into one of the biggest reasons for loss of performance in athletic horses, and honestly, a concern for pretty much all horse owners: equine osteoarthritis. You might know it as degenerative joint disease or DJD.
Right. OA, DJD, same thing, essentially.
And you've given us some fantastic sources on this, some really great research and articles. Our mission today is basically to unpack what OA actually is, how it affects the horse's body, system by system almost,
Uh-huh.
how vets figure out what's going on, those diagnostic methods, and then look at the treatments, including some really cutting-edge stuff that's available now.
Sounds good. There's a lot to cover there.
Okay, so let's unpack this then. When most of us hear osteoarthritis, I think the first thing that comes to mind is just wear and tear, like old age, lots of use.
That's the common idea, yeah.
But the material we're looking at suggests it's, well, a lot more complicated than just that simple idea, doesn't it?
Oh, definitely. What's really fascinating here, and the research spells this out clearly, is that OA isn't just wear and tear. It's defined as this progressive physical and biochemical damage.
Okay, physical and biochemical.
Yeah, damage to the joint's cartilage, that smooth lining, and also the bone right underneath it, the subchondral bone. And crucially, it always comes with inflammation.
Inflammation is key then.
It really is. It's an active disease process. It's not passive. The joint is actively changing, remodeling itself, unfortunately, for the worse.
Okay, and here's something that jumped out at me right away from the sources, a really interesting fact.
Oh, yeah.
It says the hallmark of OA is this cartilage breakdown, the degeneration. But, and this is the surprising part, that cartilage tissue, it actually doesn't have any nerves. It's devoid of innervation.
That's right. It's a bit counterintuitive.
So when a horse is lame, showing pain, that pain isn't coming directly from the cartilage itself breaking down.
Exactly. That's a huge distinction to make. The pain we actually see, the lameness, it's often attributed to everything around the cartilage.
Like what specifically?
Well, think about the periarticular soft tissues. That's things like the ligaments holding the joint together, the tendons moving it, the joint capsule itself. All those structures are full of nerve endings.
Ah, okay, so they feel the effects of the damage.
Precisely. Now, whether pain comes directly from changes in the subchondral bone underneath the cartilage, that's actually still a bit controversial, still being debated in research.
Interesting.
But the main takeaway, the thing for owners to understand, is that the horse isn't feeling the cartilage crumbling directly. They're feeling the inflammation and the stress on all those surrounding innervated tissues.
Okay, so if the cartilage itself isn't the source of the pain signal, what is actually happening inside that joint? What are the sort of mechanisms that lead to all this trouble?
Right, it's like a cascade of events, really, a multi-pronged attack on the joint. So at the core, you've got that articular cartilage breaking down.
The smooth stuff wearing away.
Exactly. And it's happening because the cartilage's own cells, they're called chondrocytes, they start to malfunction. Instead of doing their job maintaining the healthy joint matrix.
They go rogue.
Sort of, yeah. They start churning out these destructive enzymes. Things like matrix metalloproteinases, MMPs is the shorthand. Think of them like tiny little wrecking balls inside the joint.
Okay, not good.
Not good at all. They start breaking down the essential scaffolding of the cartilage. So it loses that smooth, resilient surface. It gets softer, it starts to fray, it erodes. And eventually, you can even get exposure of the bone underneath.
Wow. And I'm guessing that breakdown process itself fuels the inflammation we talked about.
You got it. It sets off a chain reaction. As that cartilage breaks down, little bits of debris and inflammatory chemicals, things called cytokines, and prostaglandins, get released into the joint fluid.
The synovial fluid.
Right, the synovial fluid.
Mm-hmm.
And that flood of inflammatory stuff triggers a really strong inflammatory response in the lining of the joint, the synovial membrane. That's what we call synovitis.
And that affects the joint fluid itself.
Big time. Normally, that fluid is thick, viscous, acts like a shock absorber and lubricant. But in this inflamed state, it loses those properties. It gets watery.
So less cushioning, less lubrication.
Exactly. It becomes a vicious cycle. You often see increased joint fluid, too, what vets call effusion. That's the visible swelling you might notice, and it causes more discomfort.
So cartilage, fluid, What about the bone? You mentioned the subchondral bone, or
Yeah, the bone underneath takes a hit too. It's designed to absorb shock, but with chronic stress and losing its protective cartilage layer, it starts to change. It can actually become denser and stiffer.
denser. That sounds like it would be stronger.
You'd think so, but it's actually less able to absorb impact. It's called sclerosis. And because it's less shock absorbing, that puts even more stress back onto the already damaged cartilage.
Ah, another vicious cycle.
Yep. And we also see microfractures in that bone from all the repeated impact. Plus, the joint tries to stabilize itself, kind of desperately, by laying down new bone around the edges.
Bone spurs.
That's them. Osteophytes is the technical term. Sometimes these can even break off, creating chip fractures. Or they can form where ligaments attach, called enthesiophytes. Either way, they can restrict movement.
And the joint capsule, the structure holding it all together.
That doesn't escape either. Chronic inflammation leads to thickening and scarring fibrosis of that capsule.
And making it tighter, less flexible.
Exactly. Further restricting the joint's normal range of motion. So you see, it's this whole combination of physical breakdown and biochemical chaos affecting multiple parts of the joint. Definitely way more complex than just wear and tear.
It really paints a picture of a relentless, destructive process inside the joint. But what actually starts it all off? What triggers this cascade? We know the exact cause can be tricky to pin down, right? Often a mix of things.
That's usually the case. It's rarely just one single thing.
Yeah.
You're right. Repetitive microtrauma, just the wear and tear of athletic activity is a huge factor, especially in performance horses.
Just the daily grind.
Yeah, the pounding. But an acute injury, like a sudden sprain, a fall, even a bad step, can absolutely kickstart the whole degenerative process too. Maybe a seemingly minor stumble that actually does some initial damage.
And what about the horse's build? Does conformation play a role?
A massive role. Conformation faults are a big risk factor. For instance, a horse that's, say, carpal varus, meaning their front legs angle inwards a bit at the knee.
Like knock-kneed?
Kind of, yeah. Or a horse that's back at the knees, where the knee looks a little hyperextended from the side. Both those put uneven stress on the joints.
Makes sense. And things like shoeing.
Oh, absolutely critical. Poor shoeing, unbalanced feet. That throws off the whole biomechanics and increases strain on certain joints. It's fundamental.
Any other major factors?
Well, genetics can predispose some horses. And those developmental orthopedic diseases, DODs, like osteochondrosis, OCD lesions, they can definitely set the stage for OA later in life.
So problems starting really young.
Right. And even things like a joint infection, septic arthritis, that causes rapid, severe cartilage damage and almost always leads to secondary OA down the road. And of course, age itself is a factor, just the cumulative effect of years of loading.
So it's often this combination, this sort of perfect storm of factors coming together.
Exactly. The interplay between these things is often what pushes a joint over the edge into OA.
Okay, so let's say a horse starts showing signs, maybe that subtle lameness or they're just not performing like they used to. How do vets typically figure out if it is OA and, importantly, which joint is the problem?
Diagnosis is really a journey. It's detective work, honestly. It always starts with a really thorough lameness workup.
What does that involve?
First, you get a detailed history from the owner. When did it start? How has it changed? What makes it better or worse? Then comes the hands-on clinical exam.
Looking and feeling.
Pretty much. Watching the horse stand still, then watching them move, walk, trot, maybe canter, often on different surfaces, like hard ground versus soft ground. You're looking for any asymmetry or signs of pain. Then you palpate the joints carefully.
Feeling for heat, swelling.
Exactly. Heat, swelling, pain on pressure, and checking the range of motion in each joint. Are they flexing fully and comfortably?
And flexion tests. I've seen those done.
Yep. Flexion tests are a key part. You hold a specific joint flexed, usually for about 30 seconds to a minute, then immediately ask the horse to trot off.
And if the lameness gets worse?
If it's significantly worse right after the flexion, it strongly suggests that the joint you just flexed, or structures very close to it, are involved in the pain. It helps you start localizing.
Okay, so that helps narrow it down. But you mentioned earlier the sources call something the gold standard for really pinpointing the exact source of pain. What was that again?
Ah, yes. That would be diagnostic anesthesia. Specifically, intra-articular anesthesia or joint blocks.
Injecting numbing medicine.
Precisely. You inject a local anesthetic directly into the joint you suspect is causing the problem.
And then you watch them move again.
Right. If the horse's lameness improves dramatically, we usually look for, say, more than 80% improvement after that joint is numbed.
Then you found your culprit.
But it's very strong confirmation that that specific joint is the primary source of the pain. We also use nerve blocks, which numb bigger regions, but the joint block is the most precise way to isolate pain to a single joint structure. Okay, so once you've localized the pain, how do you get a look inside? How do you see the actual damage? What imaging tools are used?
Radiography, good old x-rays, is usually the first step. They're readily available, relatively inexpensive.
What can X-rays show you in an OA case?
They can show quite a bit, especially as the disease progresses. You might see narrowing of the joint space, which indicates cartilage loss. You can see those osteophytes, the bone spurs we talked about, or enthesiophytes.
You might see increased bone density, that's sclerosis in the subchondral bone. In really advanced cases, you might even see the joint starting to fuse together. That's called ankylosis.
But x-rays don't show everything, right? Especially early on.
That's a really important point. Early OA changes, especially subtle cartilage damage, often don't show up well on X-rays. And sometimes the severity of changes you see on the X-ray doesn't perfectly match how lame the horse actually is.
So you might need more advanced imaging.
Often, yes. For a really detailed look, especially at the soft tissues, cartilage, ligaments, tendons, the joint capsule MRI, magnetic resonance imaging is really the gold standard.
Why MRI?
It gives incredible detail. You can directly visualize the cartilage thickness and health. You can pick up subtle bone bruising or edema in the subchondral bone that X-rays miss entirely. And you can see tears or inflammation in ligaments and tendons around the joint.
What about CT scans?
Computed tomography, CT, is excellent for looking at bone and complex 3D detail. It's particularly good for intricate fractures or really evaluating the shape and extent of bone spurs.
And bone scans. Nuclear scintigraphy.
Right, a bone scan.
Yeah.
That's very sensitive for picking up areas of active inflammation or increased bone turnover. It can often highlight a problem area even before changes are visible on X-rays. So it's useful for screening multiple areas or tracking down really subtle, elusive lameness.
Okay. Any others? Ultrasound?
Ultrasound is very valuable too, especially for assessing the soft tissues around the joint like ligaments and tendons just outside the capsule, and for measuring the amount of excess joint fluid, that effusion.
Can you actually test the joint fluid itself? Like, take a sample?
Absolutely. That's called synovial fluid analysis, or arthrocentesis. It involves carefully drawing a sample of fluid from the joint with a sterile needle.
What does that tell you?
It gives direct information about what's happening inside the joint capsule, specifically the level of inflammation. In a typical OA joint, you'll often find increased volume of fluid, but it's usually thinner, less viscous. It's lost that slippery quality. The protein level might be up. And there's usually a mild to moderate increase in the white blood cell count. But this is critical. If that cell count is very high, or if there's a high percentage of neutrophils, that's a huge red flag.
For an infection.
Exactly. That points towards septic arthritis, a joint infection, which is an emergency, and needs immediate aggressive treatment. So fluid analysis is key for ruling that out too.
Right. Okay, so we've covered a lot. We understand what OA is, this complex disease process, how it damages the joint structures systematically, and the different ways vets diagnose it, from exams and blocks to all the imaging options. The research, as you said, is clear. There's no cure for OA. It's progressive. So what does that actually mean for horse owners? What's the approach to managing it effectively? How do we keep these horses comfortable, maybe even performing?
Yeah, that's the crucial part, isn't it? Pulling it all together, the big picture is that, while, yeah, a cure isn't on the table right now, really effective management is absolutely possible.
That's encouraging.
It is. And the approach is what we call multimodal. It means using a combination of different strategies all working together.
Not just one magic bullet.
Definitely not. The goals are to reduce the pain, control that underlying inflammation, try to slow down the disease progression if possible, and ultimately just improve the horse's quality of life and function.
So where do you start?
It often starts with managing their activity level. In an acute flare-up, when it's really painful, some initial rest might be needed. But importantly, you want to avoid prolonged stall rest.
Why is that? Doesn't rest help?
Too much inactivity can actually make joints stiffer and weaker. So after the initial acute phase, the goal is usually controlled, regular, low-impact exercise.
Like what kind of exercise?
Things like hand walking, maybe some light riding on good footing, swimming if facilities are available. The idea is to keep the joints moving, which helps with lubrication, and maintain muscle strength around the joint for support, but without overloading the damaged structures.
And you mentioned farriery earlier as being critical. How does that fit into the management plan?
It's absolutely foundational. You can't overestimate the importance of good hoof care. Proper trimming and, if needed, therapeutic shoeing are essential.
How exactly does shoeing help an arthritic joint?
It's all about biomechanics. A skilled farrier can balance the hoof, which helps correct any minor conformational issues that might be contributing to uneven stress. And they can use specialized shoes,
Like what kind?
things like rolled toes or rockered toes to help the foot break over more easily, reducing strain on joints higher up, or wedge pads to change the angles and redistribute pressure away from painful areas. It's about optimizing how the forces travel up the leg with every step.
Makes sense. Okay, what about medications? For pain and inflammation, what are the go-to options?
The mainstays for managing pain and inflammation, especially during flare-ups, are the systemic NSAIDs non-steroidal anti-inflammatory drug.
Like bute, phenylbutazone.
Exactly. Phenylbutazone, or bute, and flunixin, meglumine, banamine are very common. They're effective, but for longer-term use, there are concerns about side effects, especially on the stomach and kidneys.
Right, ulcers and things.
Precisely. So for more chronic management, vets often prefer the newer generation, KOX2 selective NSAIDs, things like Vicoxib or meloxicam. They tend to have a better safety profile for long-term administration.
Are there other types of systemic meds besides just pain relievers?
Yes, there are drugs, often called chondroprotectives or disease-modifying agents, things like polysulfated aminoglycans. Equine is a common brand name or hyaluronic acid given systemically, usually by injection.
What do those do?
The idea is that they help protect the existing cartilage, reduce inflammation within the joint environment, and potentially improve the quality of the synovial fluid. There are also bisphosphonates, like Osphos or Tildren.
What are they for?
They primarily target bone pain by inhibiting bone resorption, so they can be helpful when there's significant subchondral bone involvement. And then, of course, you have the whole world of oral joint supplements.
Glucosamine, chondroitin, MSM.
All of those, yeah. The scientific evidence for many supplements is still debated, or varies, but many owners and vets find they provide some level of support for ongoing joint health and comfort as part of the overall plan.
Okay, so those are all systemic, circulating through the whole body. What about treatments directly into the joint? You mentioned joint blocks for diagnosis. Can you inject treatments too?
Absolutely. Intra-articular injections are a cornerstone of OA management for many horses.
What gets injected?
Corticosteroids are probably the most common. They are potent anti-inflammatories injected right into the affected joint.
To calm down that synovitis.
Exactly. They can provide rapid and significant relief from pain and inflammation. Common ones used are triamcinolone or betamethasone.
Are there downsides to joint injections with steroids?
Yes, it's something vets consider carefully. While very effective, there are concerns about potential negative effects on cartilage health with repeated long-term use, especially with certain types of steroids. And there's also a small but serious risk of inducing laminitis, particularly in horses that might already be susceptible.
So it's a balance.
It's always a risk-benefit assessment tailored to the individual horse and joint. Another common intra-articular injection is hyaluronic acid, sometimes given alone or combined with a steroid to help restore the viscosity and lubrication of the joint fluid.
And then there are those newer regenerative therapies. They sound exciting.
They really are. It's a rapidly evolving field, and these therapies aim more towards healing and regeneration rather than just managing symptoms.
Like PRP.
Right. Platelet-rich plasma, or PRP. That involves taking the horse's own blood, concentrating the platelets, which are packed with growth factors, and injecting that concentrate back into the joint to stimulate repair.
And I write.
IRAC-P, or autologous conditioned serum, is another one derived from the horse's blood. It's processed to concentrate anti-inflammatory proteins that block some of the key damaging cytokines involved in OA. There's also APS, autologous protein solution, which sort of combines features of both PRP and IRAP.
Stem cells too.
Stem cell therapy, yes. Using mesenchymal stem cells, often derived from bone marrow or fat tissue, with the goal of reducing inflammation and potentially promoting some regeneration. The evidence is still building, but they hold promise.
Any other new injection options?
One that's gained traction more recently is polyacrylamide hydrogel. It's a synthetic substance injected into the joint that's designed to integrate with the joint lining and provide long-lasting lubrication and cushioning.
Wow, lots of options there. Is surgery ever considered?
Sometimes, yes. In specific situations, arthroscopy keyhole surgery might be used to clean up the joint, remove damaged cartilage flaps or bone chips. And in very severe end-stage OA, particularly in low-motion joints like the pastern or lower hock joints, a procedure called arthrodesis or surgical joint fusion could be a salvage option.
Fusing the joint solid.
Yes. It eliminates the painful movement in that specific joint, allowing the horse to be pasture sound or sometimes even return to some level of light work, depending on the joint.
Okay. Phew. We have covered a lot of ground today.
We definitely have.
From really understanding that equine OA is this complex, progressive disease, not just wear and tear, but cartilage breakdown, inflammation in the fluid and lining, bone changes in
That whole cascade.
to the whole array of diagnostic tools vets use, the physical exam, the flexion tests, imaging like x-rays, the more advanced MRI, and of course, those joint blocks, the gold standard for really nailing down where the pain is coming from.
Yeah, bringing it all together, I think the key takeaway is that while no, there isn't a cure right now, effective management, really good management, is definitely possible.
A multimodal approach, you called it.
Exactly. It's rarely just one thing. It's the smart use of maybe systemic NSAIDs when needed, perhaps targeted intra-articular injections like corticosteroids or HA, exploring those regenerative options like PRP or stem cells in some cases.
And crucially, not forgetting the foundations.
Absolutely. Things like that corrective therapy, finding the right balance with controlled exercise, not too much, not too little. Maybe nutritional supplements. It really has to be tailored to the individual horse, their job, the specific joint affected, the severity.
And the prognosis. What can owners generally expect?
Well, as the sources state, it's variable, often described as guarded to fair, especially for return to high-level athletic function, because it is progressive.
It doesn't just stop.
No. And things like continuing really intense work or maybe overusing certain joint injections repeatedly, that can potentially even speed things up, make it worse. Which I think raises a really important question for owners.
Which is?
What's the real key? What's the absolute cornerstone for maximizing that horse's comfort and functional longevity when you're dealing with a chronic condition like OA?
Listening to everything we've discussed, it really feels like it boils down to partnership, doesn't it?
I think so.
That strong, ongoing collaboration between the owner, who sees the horse every day, the veterinarian with their diagnostic and treatment expertise, and the farrier managing that crucial foundation.
Communication between all three is vital.
Yeah. It's about regular checkups, being willing to adjust the management plan as things change, because it will change over time. It's definitely not a treat it once and forget it kind of problem. It's a long-term commitment to that horse's care.
Well said.
And it makes you think, especially considering what the research highlights, that OA is the most significant reason for performance loss in, say, racehorses, and that intensive training, high speeds, repetitive work are major risk factors. What does that reality really tell us? What does it prompt us to consider about how we balance pushing the boundaries of what our equine partners can achieve athletically with ensuring their health, their soundness, their comfort, not just during their career, but for their whole lives?
That's the million-dollar question, isn't it? A really important thought for everyone involved with performance horses to keep reflecting on.